Hello, hello. Welcome, everybody. Dr. Leek here with the Dr. Dustin Show. Tonight we have Keith from Invisible No More. Welcome, Keith.
I feel like this is so professional. Usually it's me and Kevin, and we're like hanging out, smoking cigarettes. It's just chilling. And
you guys
now I have to be
smoking here?
Well, you know, no comment. No comment.
I left my smokes at home today, but actually, I was going to say this reminds me of old times.
Yeah,
how we got started.
This is. Except we don't have a table between us, keeping us from going at each other's throats physically. You know, we've grown.
Welcome back to the old school.
Our relationship's grown.
Yes.
We don't need the table to.
Well, also we have witnesses, so
yeah, true.
That
this is true.
This is a live show.
So,
welcome everybody. What an exciting time we have tonight, because I think when we first started this whole podcast venture, it was really sort of shocking and jarring to me, sort of coming at it from the other side of the fence, in my own physician head, having gone through the training, thinking that, well, of course everybody's doing what they're supposed to be doing. Right? What do you mean that these, I understand there's like disgruntled patients and, situations that are beyond control and that type of thing. Not everybody gets what they expect. But the stories that have been pouring in, certainly when we first started these videos, was quite incredible, to the point where we thought we should do another episode on it.
Yeah, and we should, and because unfortunately the stories are never ending.
Right.
They're never ending, and I did a post today on social media about just how I asked for stories, and it was a mistake. Not because they're not important to get out, but because they just hit so hard. We're all invisible. And some of us go through the same treatment issues, but a lot of us just get put through the meat grinder. And
right.
It's not, sometimes it's our fault. We make mistakes, but other times it's just totally, we didn't do anything.
And exactly. And so, there's definitely, I think, some understanding that needs to happen, maybe from both sides, the patient's perspective, the physician's perspective, and the need to understand each other. And then also just patients need to understand what good care looks like, what you should be expecting, not necessarily what prescriptions you should be expecting, but just the quality of care that you need to be getting, the communication, the respect, the empathy, right? I mean,
I'm sorry, you lost me at communication.
Well, exactly. That's why we're here tonight.
Well, and that's, I think as you see some of these videos and we go through some of the comments, either on paper or from people in the gallery tonight, that's going to be something that just doesn't exist. And while maybe some of it is the doctor's fault, some of it's the patient's fault, but I think a lot of it is going to fall back to what we talked about a few weeks ago. It's 15 minutes. And what can be, you have to,
if you're lucky.
Yeah, you have to average 15 minutes per patient. Mm-hmm. And it's awful difficult. It's not impossible with the right doctor, but it's very difficult to get accomplished.
Yes, that's very true. And, I think there's a couple factors, like you were mentioning the 15 minutes. There's obviously major problems with the systems that we have to work under. And we've touched on that to some degree on podcasts in the past. But also, I think there's a inherent human problem when it comes to understanding someone who's in pain when you yourself are not in pain. And you would think that as a physician who specializes in pain management, or even a nurse or an MA, or an employee that works for a pain management clinic, you would think they would also have that training, and they should even just display it, even if they don't feel it. However, again, that doesn't always come across.
It doesn't always come across. And I think one of the reoccurring themes you'll hear tonight is, please listen to your patients. Please listen to your patients. I think that's what's going to be coming across. Maybe try to ignore my medical record or this test that came back normal. Again, we've talked about that, right? About, tests are normal, and how that can truly impact a patient. While it's great, it's normal. I don't have cancer. I don't have an answer. And,
right.
Too many times it's written off, it's in your head. We have cases here in my notes where a lady went to the ER due to a gallstone, and she had documented in her medical records she was having problems with the gallstone. and they sent her home. No pain meds, just with a referral to go see somebody else. And 5 weeks later, emergency surgery. Right.
Right.
So.
Oof. Yeah, someone wise once said, if you listen to your patient, they will tell you what's wrong with them.
Well,
I think that was William Osler, Sir William Osler. If somebody knows, go ahead and put that in the chat. I'd be curious to double check me on that. But yes.
Do they still teach that?
Well, he's long gone, if that's who it is. But yes.
Because it doesn't seem to be coming out.
You should be listening to your patients. So I think we have a video to get us started, Kevin. We have a few videos tonight. We have some text that we're going to go over. We have the chat actually live on the television right in front of us.
Yep.
So we can see you, with a few seconds delay, of course, coming in. If you have a story, go ahead and type it all up in a Word document, and then you can paste it into the chat if you feel so inclined, and we can read it live on the show tonight as well. So
love to.
Kevin, whenever you're ready, let's roll that first clip.
Let her rip.
To share some of my experiences with pain management docs and pain management clinics that I've had over the years. I'm part of the Invisible community, and I have been in pain since 2008. My first injury was 2008, and back then there wasn't such a thing. There was no pain management clinics or pain management docs. There was your primary, and you went to primary, and you went to physical therapy or chiropractor if you wanted to, but basically it was, you work as a team with your primary care doctor, and that was how you got through the day, whether it was medication, whether it was more physical therapy or different physical therapy. That's how it was back then. So we're going back almost 20 years. And that's how it was for about a decade, until about 2014. My husband got sick, and I became his primary caregiver. And as a primary caregiver, what you do is you put yourself on the back burner. And I did that. I stopped everything for me, and everything was about him. Unfortunately, that was about 3 years of ignoring me. He had passed away, which added the PTSD diagnosis to things as well. But when I came back, when I woke up and said, okay, I really need to find a way to live better. I need to be able to get through the day without having difficulty walking. And that's when I realized that pain management clinics were around. And I ended up moving, and I was near places where there were about 4 different pain management clinics. And I ended up going to each one. The first one, the doc was in an accident. They had to shut down. So, all the usual things, I ended up seeing quite a few different docs. The big difference, huge difference, was it felt to me like a blackmail program going on. If you don't do this or this, then you're not going to get physical therapy, you're not going to get medications, you're not going to get whatever it is that you might need that might help you next. You're not getting that until you do this. And one of the first things was spinal cord stimulator, so I had that to be able to get to all of the other steps. And that unfortunately didn't work out for me. I had about 60 injections, all of them very repetitive, each repeating what the prior clinic had done. None of them worked. And unfortunately, I couldn't go back to any one of these doctors and say, all right, here's what happened. I didn't like it. It didn't work. Here's all of the things that I'd like to try instead, because they didn't want to have that relationship. They did not even try to get to know me or my body. I mean, look at my MRI. Try and see what do you see in my MRI? And that's not what happened. So I would say that the most difficult thing with dealing with those kind of docs is you're a number. I really felt like that was it. I was a number. I wasn't going to get anything unless I, decided to go ahead and do the injections. Since then, I've gone back to my primary, and I'm in another holding pattern where she knows me. This new primary that I have knows me and trusts me, and we work medications out, physical therapy, different things. But I need to go to a pain management clinic. I need to see a pain management doctor. But there's nobody around that wants to treat me as a person and not a number. And I know that's, it's very difficult. I'm in a kind of a rural area, and to have access to a few of them is very lucky on my part. But that's where I'm stuck. I'm in a holding pattern until I can find a place that wants to treat me like a person, wants to get to know me, wants to get to know my spine, wants to get to know what my story is. I'm 62 years old. I kind of like to have a different kind of program that's going to get me through the rest of my life. So that's pretty much it. If y'all have any questions, let me know.
Wow.
That's Carol. And it's amazing she has a primary care that's willing to help her out. But at 62, she's looking for a pain doc for a plan. I mean, this goes back to, we're not all med seekers. She's getting some relief with meds, but she's searching for other things that may help on top of that.
So, a couple of things popped out to me there. First of all, she expressed what I believe to be a genuine desire to be seen as and treated as a unique individual human being. And I don't think that's too much to ask when you go to your physician. And what's interesting is when, we go through medical school, at least at my medical school, there's a huge a patient as more than a number, but as a person, a father, a mother, a daughter, a son, someone who has a life to live, someone who has people depending on them. And so that's ingrained into us in medical school. I don't know what happens along the way if you're just jaded, if you're just overrun, if you become callous, or whatever that, the system beats you down. It's not right, and it's pretty much a soulless way to practice medicine. If you're a physician going into that, there's no fun in that. The fun is getting to know your patients one-on-one. So I'm sorry that it's coming to that point.
We talk about a lot about how a goal for a pain patient or a chronically ill person or somebody dealing with mental health is when the doc walks up to the exam room and you have the file in your hand. You don't look at it, the file, and go, okay, another bad back, and walk in.
Right.
It's like, I feel for you, because they hand you the file as you're walking down the hallway, and you look at it and you go, Keith Johnson, what the hell's going on with him today?
Right.
Right.
Yeah.
But I want you to have that type. I want my doctors to have that type of thing. Why is he here?
Yeah.
What's going on with him this time? There's a myriad of things, and patients are begging for that. And I don't know if it's jaded. I don't know if I have personal opinions about some that it's a financial thing.
Oh, 100%. Yeah.
And that's why as many patients they get in, the more they bill, the more,
You're in the wrong business. I know doctors that do this for money. I mean, I've rubbed shoulders with them. I know people that work in their circles. They're not pleasant people, these doctors. Well, I don't think they're very happy.
But imagine being their patient.
Well, exactly. Trust me, I know. That's my point. Well, it's like the patients are unhappy and the physician's unhappy. Like, there are 1,000 better ways to make money than by running pill mills or just making decisions based on profits. There's 1,000, but you're not going to make enough money in this business. There's no possible way. It's going to catch up to you. Your reputation in the community is going to be harmed. Your Google reviews are going to be harmed. Nobody's going to want to refer patients to you because everybody knows what you're about. And eventually you're going to have to move towns.
But see, the problem is there's so few pain management specialists out there.
They can just get away with it?
They can get away with it.
Yeah, well.
Right? And what, 4 quarter? No, not even that many, right? 4 a year.
Why did that second doctor even ask for your records?
Yeah.
Why does that doctor care if they're not going to look at it and make decisions based on it? Honestly, otherwise you're stupid. Oh, this patient already had 60 injections. Let's do 61 injections.
Yeah.
It's like,
it's the hoops that we have to go through.
No.
And I know you hate it when I say that.
Well, there is gatekeeping.
Right.
The term blackmail was being used. That may be accurate to some degree, but I would use the term gatekeeping, because a lot of physicians, well, first of all, opioids are always at the end of the treatment protocol.
Correct.
Right. Let's just be honest about that. Whether it should be on an individual level or not is debatable, and that's where critical thinking comes in. But when it comes to protocols, it's always at the end of the plan, of the program. Now, sometimes patients are not good candidates for non-opioid treatment. We talked a little bit about this. If you're over the age of 65, your chances of heart attack, stroke, kidney problems, stomach problems all go up. So are NSAIDs really the best medication for you? Or anti-inflammatories really the best medication for you? Mm-hmm. What about gabapentin and its problems with balance and muscle relaxers and the risk of fall? Like, these are all considerations too. Apparently nobody considers, oh, but your 65-year-old, grandma or grandpa is going to get addicted to this stuff. Yeah. So, I mean, that's my point. It's like, not everybody has the same risk. We've talked about pain management as risk management in the past.
With a pain patient, the extreme of a nerve stimulator. Not everybody's a good candidate.
Not everybody's a good candidate for nerve stimulator.
And I think when you were talking about that on your lives, and we've talked about them in the past, one of the things that really got me, that really hit hard for me was how you have your the psych exam, right? You have to score a certain percent for you to even think about doing it, right? Or some doctors, right? Because it may work.
Right. Sure.
Where that to me is criminal.
Yeah.
Because the chances, all that work, all that expense for a 50-50 for a coin flip.
Right.
Right. I don't, but some doctors do that.
Every decision that is made in medicine needs to come with a proper professional analysis of the risk to benefit ratio. And so, that pain management is no exclusion to that. And in a lot of cases, yes, the use of opioid therapy may be higher risk than something that's non-opioid therapy, but the converse may also be true. I think the problem is we are so heavily protocolized in our approach, and so strongly practicing with gatekeeping methods to the point where we're harming patients, deferring proper management, deferring proper care, and somehow we're okay as pain doctors for our patients to be bedridden for a year. Well, as long as we're not prescribing opioids,
well, that's it.
That's it.
I think in one of our I think it was the very first podcast we did, because I think when I was sitting on your sofa, I heard you tell me about some doctors that were bragging they got 90% of their patients off of all opioids.
It's a badge of honor. Yeah.
Right. Mm-hmm. Shouldn't the 90% that they're shooting for being patient care?
Right. The statistic that you should be looking for are the number of patients that are functioning with minimal pain. Functioning well with minimal pain. That's the outcome that we should all be achieving.
Right.
So it's like, if you can do that with minimal opioid use, okay, but why is that the statistic? I'll tell you why that's the statistic. It's because that's what we all get graded on. Mm-hmm. That's what all the outcome studies are when you're looking at pain studies. Oh, well, we tried this therapy and this therapy worked. How do we know it worked? Because this number of patients reduced their opioid use by this amount. That's great. I mean, that can be a good outcome measure, but is it a badge of honor? Is that why we're here? Is our sole purpose as a pain doctor to reduce opioid use? Not primarily, I would argue. Secondarily, sure, perhaps. Tertiarily and all the rest. I mean, who wants to be stuck on medication their whole life? Just blank statement, right?
Not me.
But as a pain doctor, your role is to improve your function and reduce your pain as safely as possible. Sometimes that includes long-term prescription medication. Nobody balks at high blood pressure medications.
Or
insulin, which, I mean, how many hospitalizations and ER visits do those two things result in every single year?
Right. Yeah.
People passing out, becoming hypoglycemic, so that's where we're at. It's like, well, okay, you need opioids to live. Oh, well, you're addicted to opioids. Well, I need insulin to live. Oh, you poor thing. You better get your insulin. Well, what the...
Well, see, now, y'all, did you notice the switch here? Now he sees it from our point of view, right? Not that you never did, right?
But, I saw it, but I didn't understand the gravity of it.
But the validity to an invisible patient to have a doctor just express what you just did is freaking huge, because we don't get that as a general community. What Carol just expressed, Carol wants to try different things to have a better quality of life. She's begging to, but she can't find a doctor that will sit down and talk to her to figure out what's going on and what can we try that you haven't tried yet. Right?
It sounds like that doctor didn't read the records.
Any of her doctors, right? I mean, it's because it, and if I guess if you know, we talk about maybe talking to baby docs and expressing some issues that patients have, that is an issue. You have a patient that wants to do things to try to get better, and all it takes is getting past what this medical record said or this said and have a conversation. So you tried this. It says it didn't work. What do you mean it didn't work? How didn't it work? Did it improve at all? Okay, well, what else can we try? Okay, did you try, you know, and keep going down the list, because all of us, all we want is to have a little bit better quality of life. That's it. And whether if we have to have an opioid, great. But if that means some PT, or if that means some other type of treatment, ketamine or whatever, okay, give it to me, try it. And in Carol's case, she's done. Carol, I'm not trying to put words in your mouth, so you can correct me if you're here tonight. But if she's trying and it's not available,
Yeah.
and it just breaks my heart, because
Yeah. I know. It's not a good name for pain specialists. I mean, that's the whole thing. You should be able to offer something as a package, a delivery. What is it that you're selling? You're selling function and pain relief. You're not selling no opioids. Yes, that could be part of it, but you're selling those first two things. If what you're doing is not achieving those first two things, what are you doing?
yeah.
Do you want to go to another one? Do you have something to read?
I think we have one from Shelley.
Okay.
We have two more that I want to get to tonight. I want to get to Shelley's and I want to get to Kimberly's.
Do we need to go through the comments real quick? I want to make sure.
I know that
before it gets too deep.
Way back up. There's a lady, Buck, had a horror story that involved cops coming to her house, I believe.
Oh, let's check that. Okay. One of my horror stories, I'm going to read this, Buck, is when my GP was transitioning to being a hospitalist. He referred me to see his pain management friend, some big deal, an hour away and half away. And when, cliffhanger. When I got there, I'm handed a sheaf of papers at the window and told to fill them out, and I had to sign away permission for counts and UAs. And my problem was,
the problem was, I guess, that the sheriff's office, paperwork said the sheriffs could enter her home at any time.
What?
This was in 2015.
The sheriff's office enter my home. So this was on the paperwork. You had to agree to this, that the sheriff's office could enter your home at any time. And I said, I don't even want any meds. I just want to see the doctor to see what my options are. And I was told that if I didn't sign it, they weren't. I could not see the doctor. Oh God,
that's a real thing.
That's a real thing.
That's a real contract.
Trust me, and I know Buck. Buck ain't making this up.
Wow.
Buck is not making this up. Buck doesn't need more drama in their life.
That's a first.
Yeah.
I mean, wow.
Bless.
That has to be a unique clinic issue. I don't know what state that's in, Buck. Maybe you can tell me. But at least in Texas, that is not a requirement. First of all, for you to see me or any pain doctor. You don't have to sign your life away. All you have to do is consent to treatment, which is a standard, hey, I'm here and I understand that I'm going to be getting medical advice type consent.
I wonder, I mean, I see Buck's pausing at that, because I would have paused at that too. I would have walked out. But I wonder if this was that doctor's attempt to try to weed out truly people who are there abusing the system, just trying to get medicine
it could be.
To use.
That's a good point.
I wonder. And I'm not trying, y'all, I'm not trying to defend all doctors tonight. I'm just wondering, that's just the first thing that popped in my head, is that he's had problems, multiple people coming in actually doing the wrong med seeking in the wrong way. And that's him trying to weed it out right at the front. But does he understand how offensive that is to a person who's been through the meat grinder as a chronic pain patient?
Guilty until proven innocent. Yeah.
Yeah.
That's crazy.
I mean, that's just horrendous. It's just taking a sledgehammer to, but that's how we're treated. because there's so few of y'all, and it gets away. Oh, we got one more about a doctor. Alicia shared one about the doctor wanting to try to have sex with her for pills, and we'll get to that one later.
I'm sorry. Can you go ahead and read that now? You
gonna
cannot
say
just
I was
put
gonna
that
tease
out there.
No, let's do
What a
Let's do
cliffhanger.
Shelly's video. We'll get to that here shortly.
I'm not going to sit through another video, Keith,
This is a
wondering what
good
you're
one.
talking about.
Shelly's is a good
Okay.
video. Shelly's a retired nurse.
Okay.
And just had massive heart surgery and had some complications. And she's curious about why they sent her home with what she did.
Okay.
So
Why don't you cue that up, Kevin?
I'm at home recovering from complications of a triple bypass. I'm a chronic pain patient and I have multiple autoimmune diseases, some of which are very rare. I had a reaction to the wires closing the sternum. They went in and removed those. I have a Pseudomonas infection and I am now healing by wound vac, by granulation. I have an open wound to my chest that is 15 centimeters by 5 centimeters, very painful at times. Different type of pain than what I have with my chronic pain due to my autoimmune disease. I was discharged from the hospital both times with Tylenol, 325 milligrams every 4 to 6 hours. Very ineffective. I was able to advocate for myself and get a 7-day supply post-hospitalization this time with tramadol every 6 hours, 50 milligrams. Still ineffective. I don't understand why opiate pain management for something like this is not acceptable. That because I'm a chronic pain patient and have autoimmune disease, I should not have been discharged with 325 milligram Tylenol. I have NASH. I have liver damage from years of ibuprofen and Tylenol use. It's documented in my chart. I don't understand why we have to fight so hard for adequate pain management when I just never would have suspected that as an open heart patient that I would be discharged with Tylenol 325 milligrams. How does that make sense? Thank you for hearing my story.
Wow. That sounds like it hurts a lot.
Kevin was nice, and he didn't show the full. You can see when she's sitting, laying in bed like that, you can see the wound vac thing covering her chest right there. And that's, to me, a very valid question. She has documented histories of liver issues and sent home due to,
I wonder, was she on opioids before?
I believe she was.
So she's opioid tolerant. We could assume.
Yeah, I believe so. Yep, I would assume.
Okay. So first of all, let's talk about the surgery. So a sternotomy is essentially where they take a buzzsaw and they slice your sternum bone, the bone itself, in half. And whenever they're doing the heart surgery, they'll pull your chest apart. Sometimes ribs break, but not always. And then, they close it back up. They sew that bone back together with literal wire, like you might get at the hardware store. And they coil it up and then bend the coils down so they sit flat, under the skin. And it sounds like, so that alone, assuming there's no complications, is going to be, as you can imagine, quite
Horrendous.
painful. Now, we see those patients in rehab not infrequently. And yes, they do require stronger opioid medication more often than not. But in her case, it's unique because she had an infection with an open wound that requires a wound vac and dressing changes. So you have all this inflammation and just the recurring access of this raw tissue with a bone that's wired underneath that.
No, there's no wires there. They took the wires out.
Oh, they took the wires out. Oh, she had a reaction to the wires, so they took them out. So, but that's my point is like, oh, well, here's some Tylenol. That should do it. God.
You know what I've heard? Why? Because this isn't Shelly's not the first person that I've heard this from. The very first live I ever did with any invisible person was a lady named Tammy, and she had the exact same surgery emergency, and they sent her home with Tylenol.
Yeah,
not extra strength, but regular strength.
Just regular
Tylenol.
strength. Oh my God.
They told her because opioids depress the system. and they just did heart surgery, and they didn't want to take a risk of the opioids slowing their heart down while it healed.
Okay, well, whether that's true or not, I applaud the physician for giving a reason.
Well, yeah, okay.
At least we got a reason.
Right.
Take your wins when you can get them. Yeah. So let me come back to that. So in the first case, you're talking about a history of liver disease. So definitely you want to avoid Tylenol. But it sounds like the amount of Tylenol they were sending her home with was not enough to really do much damage. Theoretically, you can still have. Now, this is not medical advice, but theoretically, you still can have up to 2 grams of Tylenol per day. That's 2,000 milligrams per day with really bad cirrhosis. Some liver doctors will disagree, but that's the protocol. So you can do that. Oxycodone and hydrocodone, you can get formulations without Tylenol. Even opioids are not super great for the liver, but probably better than Tylenol. Same thing with NSAIDs. In this case, if you're opioid dependent or opioid tolerant already, what's tramadol going to do? Tramadol is like Tylenol already. Yep. If you're brand new to opioids, tramadol may be an effective choice in escalation from Tylenol in that scenario. However, she's saying that she tried tramadol and that still didn't work. So it sounds like if the cardiologist or the cardiac surgeon, feels uncomfortable writing stronger pain meds, then they should have a pain doctor in their pocket since they're doing these bigger surgeries that can help manage those patients.
All right, so you ready for the catch to that? The pain doctor will defer to the cardiologist because that's a more serious health issue.
Boy, nobody wants to touch that.
I'm not trying to be argumentative, but I'm explaining to you real life situations.
I mean, I can't solve all these problems, obviously, but
this is what's important about this is at least you're letting us expose them, and at least we can get some of this stuff maybe to different doctors to see a patient's take on it.
There needs to be communication between the surgeon and the pain doctor, and it is ethical to treat pain, and it's unethical to not treat pain. Now, there may be reasons why, maybe life and death reasons why, but that needs to be a discussion. And none of this hot potato type stuff. And it's unfortunate that we're in that situation.
Yeah, but it's
wow.
But doctors are overworked, too many patients as it is, and the risk factor.
Now, I have a solution for that second patient that you were talking about.
Which one?
The one that got sent home.
Oh yeah, with the Tylenol.
With the Tylenol, because
just like Shelley did.
The surgeon said that an opioid would depress your cardiorespiratory system. I mean, that is a true statement, and not everybody's heart after surgery like that is very strong. Mm-hmm. But that doesn't negate the need for pain management. I would be pissed if I got sent home with Tylenol and I'm like in 10 out of 10 pain. I'd just be right back in the ER. So the solution there would be just to admit the patient. If you're worried about
exactly right.
the cardiorespiratory, put them on a monitor, put some oxygen in their nose, give them proper pain management. I mean, it's not going to last forever. It should get better.
Shelley and I talked about it a few weeks ago, and that was my first thing. If they're worried about your system getting too depressed, but
they're going to send you home.
Yeah, put me back in the hospital.
Yeah.
Right? At least for 2 or 3 days. At least give me some relief.
Right.
Because my fear is my heart's going to, I want to say a heart attack again, but something's gonna break on the inside.
Oh yeah.
Right? There's documented cases of patients not getting pain meds and end up having heart attacks and they passed away. So it's
talk about a stress on your heart.
Yeah.
Yeah.
So all right, so you want to get to Alicia?
Okay, go ahead.
All right, so I posted some videos, obviously y'all know, on social media about tonight, about Doc and I sharing some of the horror stories, and I've got some of the comments that people had left, and this one was from Alicia, I guess, or it could be Alicia Farms. One tried to have sex with me for pills.
Hold on, what? Okay, who did what? When?
Alicia is the patient.
Okay.
One doctor tried to have sex with me for pills.
So he was gatekeeping the pills for sex with the patient.
Correct.
Okay. Wow.
Incredible.
Just when you thought you heard it all.
Yeah. Obviously, that didn't fly.
I would imagine not.
And she goes on to basically describe that for years, he went to the extent of calling other people in the hospital network and other doctors in the area and claiming she was just med seeking. So when she would make appointments to go try to establish new care somewhere, there was no pain relief because it's documented already. She's on a blacklist, med seeker from another doctor because she refused the advances.
Mm-mm-mm.
And I tell you what, as this may be the first time somebody has left a comment like this. I don't doubt it. I don't doubt it. And I love you and I respect you as a doctor. But some of the stuff that patients have been put through, I'm not surprised.
It goes deep.
I'm not surprised.
Yeah. Well, we get these emails every now and then from the Texas Medical Board letting us know which doctors' licenses got suspended or revoked based on the fact that they're no longer safe to practice medicine in our community.
Is that public knowledge?
That is public knowledge, yeah.
Really?
Mm-hmm.
Reactions?
They don't always list the reasons why. Sometimes they do, or the reasons are somewhat vague. Alcohol misuse is a prevalent problem. There are some cases of sexual abuse. Something like that, I would imagine would generate an investigation at the very least, depending on where that doctor is from the state and how prompt your state is to respond to such things. But I mean, obviously that needs to be reported. I trust that was reported.
But do you know how hard that's going to be to prove as a patient?
You may not be able to prove it, but you can at least make the report. It's on file. And when something, because you can't be making decisions like that in that position for very long. I mean, some doctors do it longer than others. What was that, like Dr. Nasir with the Olympics? He made the news for a while.
Yeah, well, he abused all those poor girls.
I mean, he got away with that for several years, but eventually it caught up with him. But if you have a trail, then you can start linking back,
Cases back and back and back.
Definitely that needs to be reported. I'm sorry that happened to you. Wow.
That's brutal. But it's just, again, shows, I mean, I could see it happening in a PCP's office, I guess, but when you get to a specialist, neurologist, pain doctor, GI even, to where there's limited access for a patient, things happen. And some doctors just take advantage of that situation, as horrific as this is. But it's horrific for people like Shelley being sent home with Tylenol from massive open heart surgery.
Yeah.
This stuff is it's rampant,
Yeah, boy. Okay, so let's see. Getting back to the comments, let's see here. I walked into my old pain doctor and he cut me completely off, sent me into withdrawals, had a heart attack. Wow. That was another major form of malpractice, and I will call it malpractice. Because it is malpractice. After the 2016 guidelines that put everybody into a frenzy from the CDC, and doctors pretty much overnight were dropping their patients either completely or by some significant amount where they were going into withdrawals. And not only did that cause a bunch of pain and suffering, but then those that didn't have any access all of a sudden immediately went to the streets. I mean, what are you going to do? I don't think people understand, doctors don't understand always the power opioids have on your body when it comes to developing tolerance and going through withdrawal and all that stuff. It's like a seizure medicine. And you have to wean off of that slowly if that's the decision you're going to make. To cut you cold turkey is absolutely malpractice.
It's cruel.
It is.
I mean, protect your license. I get it. But at the same time, where's patient care? I'm not even thinking about I'm tired of hearing do no harm, right? And the doctor's oath and stuff. I'm tired of that, right? I'm tired of hearing that. Just human level, one-on-one compassion. Where is it? And in a lot of cases, the cases we're talking about tonight, cases that I hear, I mean, I had a total meltdown this morning after listening to Kimberly's story because all this stuff was adding up. Right. And because there's just such an immense level of compassion in specialty offices across the board. Because, and the only thing I can blame it on is that they know that there's limited access. And that if they lose us as a patient, that's okay because there's somebody waiting in line. And it's like I went through with my previous doctor. If I didn't get the nerve stimulator, he knew that eventually I would leave. That's fine because that opens up one more slot for him to bring in and try to do something else with somebody else, right?
Yep.
And but that's just an example, you know, of what goes on, and it all goes back to me just communication.
Mm-hmm.
And I would think it's better for a pain management doctor to have a patient come in and take the time initially to build the relationship to see what the hell's going on, and work plans until we find something that gets the patient stable, maybe even improving some, but they stop losing quality of life. They freeze that. It's at least stuck where it's at. It doesn't get any worse, because once you can at least get that, then that's a little bit of pressure off the entire situation. Does that make sense? Mm-hmm. It doesn't just become, I'm not even saying that it's just refill days once a month, right? It could be refill days of an opioid, but it could also be refill days of a muscle relaxant or of a ketamine or another script for PT or sending them a referral to a therapist or something like that. It's not as difficult because once you start knowing the patient and knowing what's going on with them, you can get them to where they're not crashing, continually going down. And if you can freeze that seems to me that would take a little bit of the pressure off.
Yes. Working in pain management is a high stakes situation. Not only do you have all the regulation and whatnot that you have to be mindful of, but the patients themselves are high risk patients. And I don't know that a lot of pain doctors have a real appreciation of that, with the idea that living with chronic pain on a day-to-day basis is tremendous. It's a huge, overwhelming burden. And if your pain doctor, the one person who's supposed to be in your corner, creating a path for you out of this nightmare, if that person is your biggest resistance, is your biggest person that you fear in this whole process, how are you getting any type of therapeutic progress out of that? You're not. So speaking to other doctors out there, as a pain physician, if you want to do the most good for your patient, build that rapport. Start, especially in that first visit, do your due diligence. Look at their chart. Understand what exactly got them to this point, what it is that they tried, what it is that they failed at, what worked for them, what can they have, what can't they have. And I'm not saying you have to give them this or do that or whatever, but you have to be able to meet the patient where they're at so that patient is seen by you. And from there, the conversation will blossom in any which direction. But already that patient is going to be much more willing and trusting of your opinion. To go in there, I mean, correct me if I'm wrong, Keith, but to just go in there and just shoot from the hip and be like, yeah, I looked at your chart and we don't do this, but you need this. And what do you think? Well, hold on. You don't even know. Well, if you're not going to do it, then I'll just go to the next patient. See you later.
That's it.
And that's probably what a lot of you are experiencing.
A lot of it happens, right? And
why are you doing this business? There's no purpose. That's such a bad way to live your life.
That's what we say too,
yeah.
Right? Because all we, in general, and all an invisible person wants is to try to be a little bit better every day. We don't want to keep sliding backwards.
At least maintain, maybe.
At least maintain.
Yeah.
Right? And if I can't get on the ground to play with my grandkids, what can we do to get me there?
Right.
To try to get me there. I'm not looking to go climb a big mountain or go run a marathon. I just want to be able to get on the floor, play with my 3-year-old grandkid for 10, 15 minutes, and then get back up off the floor without having to get the National Guard out to help me get it done, and not suffer in bed for 3 days afterwards because I was on the floor for 15 minutes. And that's not trying to go run a marathon. That's just a little bit of glimmer of quality of life. And
I tried to run a 5K a couple days ago. Oh, that was horrible.
I saw you got a participation trophy.
I did. Hey, remember, the slowest runners get medals too.
Yeah.
Some of you will understand my analogy there.
Yeah.
It is what it is.
It's like in baseball when you come in last place in the tournament, you get a ribbon. I don't want to go there. I'm going to be quiet now, or I'm going to be in trouble as my pain doctor.
As long as you can afford the tuition. I mean, the cost of the race.
That's it.
Yeah.
That's it.
Do we have another video?
I have another video.
Okay.
We got one from Kimberly.
It's a little long, but this is the one that set me off this morning. That spiraled me today.
Years old, and I'm just going to get right into it because I know our stories are long. So, for years, I lived with worsening autoimmune and neurological symptoms while trying to find answers, and those symptoms were just progressing to a point where they were impacting so many aspects of my life. I felt dismissed or misunderstood by providers that I was going to see. My pain and my symptoms were viewed more on a level of suspicion rather than curiosity. And that unfortunate thing delayed diagnosis of several illnesses by decades. Those illnesses are neurosarcoidosis, sarcoidosis, systemic sclerosis, Sjogren's syndrome, and rheumatoid arthritis. I was attempting to manage my life to a young child, trying to work, trying to function in a body that was screaming for help. I had symptoms very alarming, ones that would wake me up as I was sound asleep through the night. The best way that I could describe them would be excruciating shots of pain, like lightning through the body, stroke rate, blood pressure, alarmingly high heart rates. And even as I was telling providers what was happening, still I was looked at more on suspicion than anything. I had lab results that were off, but not quite off enough. It unfortunately took my husband rushing me to the emergency room as I had stopped breathing and had begun having serious, violent seizures, for them to begin finally hearing me. Like so many pain patients, complex patients, and doctors alike, attempting to navigate the state of our current medical system comes with tremendous challenges on both sides. Unfortunately, from a patient's perspective, you are thrust back into a system that is judging you based on suspicion, having to continuously prove your illnesses, prove that your pain is real, and prove that you yourself are worthy of having your pain treated properly and adequately so you can live the life that you have with dignity and enjoy it. I personally, as a patient, have experienced many situations where the system that is designed to help me and is supposed to protect me has worked vastly against me. At one point, I was told a medication that I take daily had not shown up in my UA at my doctor's appointment. This caused me to leave the office that day being dismissed as a patient from the facility, as they have a no tolerance policy, and left without my prescription for medication, which was due to be filled the following day. They wouldn't hear any of my side of the story and refused to do a confirmatory test. I was left trying to understand what possibly could have happened. I was a compliant patient. I had to spend hundreds of dollars out of pocket to find the answer for myself. And I did. Unfortunately, due to one of my conditions, I'm also a rapid metabolizer. Thankfully, my doctor ended up listening to me and allowed me back into the facility. But that was after almost 2 months of going without medication that I had taken daily as a compliant patient. I had to come with all the tests I had paid for out of pocket to discover what possibly could have happened. Another time, I pulled up for my routine monthly appointment, only to find that there was a notice on the door. The office had been shut down. The only telephone number to call at the bottom of the paper led to just an answering service. No return phone calls. And again, that meant that my medication was due to be filled that day or the following day. So patients were left scrambling, not just me, but everybody, left scrambling to find what we were going to do. Once you become dependent on those medications, to stop them suddenly can have detrimental impacts. Many patients like myself were forced to go to the hospital to seek treatment, as many primary care providers either were unable or unwilling to fill the gap to help these patients who, again, had been compliant patients through no fault of their own, left searching for help in a system that's supposed to protect them, designed to work against them. If you are a patient lucky enough to find adequate pain treatment from a pain management physician, then monthly we have our doctor's appointments, which there's such a shortage right now for pain physicians that many of us, like myself, have doctors that are 2.5 to 3 hours one way. That's every 28 to 30 days. Traveling alone when you have many of these conditions is impossible, so then you need a spouse or a caregiver to help you with transportation. Just the car ride alone, every bump. Temperatures outside, fluctuations in season make it extremely difficult for many of us to get to our providers. And then the fear sets in, the instant trauma and PTSD from all past experiences, from wondering what you're walking into today. Are you going to be able to leave with your prescription? Are you going to be listened to? Is your doctor that you've developed a relationship with through many years going to be there still? Is the facility going to be open when you get there? And then when you leave, of course, the journey's not over, because then you have to deal with your pharmacy. And that's if you've got a pharmacy where you're not held under the same scrutiny as pain patients are everywhere else, it seems. And then if you've got an amazing pharmacist, it's, golly, is the medicine in stock? Is it there? Because there's been cuttages in the supply chains on many of our medicines, and that's a nightmare in itself. If they don't have your pain medicine and it has to be ordered and you're without your medicine, then what do? Hopefully you can reach your doctor in time before the office closes to get something different or a different milligram. And if not, well, the anxiety in itself is debilitating. That anxiety is felt for myself at least a week before every single appointment I have every single month, because truly my life depends on this medication. At this point in my journey, although I'm considered palliative care, unfortunately, palliative care doesn't include pain management. So when I say that my life depends on this medication, I mean that at this point of my life, it depends on this medication. so I can enjoy what I consider the finer things in life. So I can live my life with dignity. So I can share and create memories with my family, with my daughter, my 2 granddaughters, with my husband, with my loved ones, with my dog that you've probably heard snoring in the background. That medication allows me to make and create new memories, to be able to live the life that I have with the conditions that I have, but to be able to live the life that I have. If sharing my story helps just one physician, new physician, stop and take pause and listen a little more closely and look deeper when a patient says, hey, something isn't right, and I've tried everything and I'm still in pain, then sharing it is worth it. Because I can promise you, my life and others depend on it. And my life and others are worth it. We are worthy, we are valid, and we are here. We shouldn't have to be invisible anymore.
Yeah.
What a powerful testimony.
I got that this morning, and it's been with me all day long. Everybody's story has been with me all day long.
Mm-hmm.
All of y'all's stories, and plus the hundreds of more I hear. But I wanted everybody to see, excuse me, Kimberly's story tonight, because I think it wraps in so many different problems that a lot of us have run into, from not being listened to being a number, to hoops, to doing nothing wrong and missing a UA, nothing that we did wrong, to closed clinics, to pharmacies, either hopefully willing to get you your meds, and then when they agree to do it, then there's the shortage because the DEA is cutting production. And we were just talking, I was just trying to explain earlier about how all we want is quality of life. And I said, we don't want to run marathons. And Kimberly's, she puts it exactly beautifully better than I could ever put it, when all she wants is memories with her family. But she's dependent on these meds to get that quality to make just memories. Not running marathons, not going to Disney World every couple of months, not going doing crazy things. Just making memories, maybe going out to dinner.
The things that so many of us without pain take for granted. We don't understand the possibility of not having them. The ability to create memories, to spend time with your family. It's so easy to just dismiss that concept, I think, from the other side.
And she nailed it from the beginning. Just listen. Pause for a minute and listen. Maybe it's 17 minutes with that person in that room that day.
Yeah. Yeah.
Right? Because if you've seen this person on a regular basis and they're telling you that everything that they're being compliant and they're following this plan that you've put out, and it's not working, the pain is still intense and it's still there, something's not right. Pause and just think. Don't just say, well, yeah, think in your head, are they really following the plan? I can guarantee you that the vast majority of us invisibles, we're going to follow that freaking plan to the T, because we want nothing but to be a little bit better.
I will say this, Keith. The number of drug seekers that have come through my door has been significantly less than what I was expecting based on my training. Yeah.
Imagine that.
Imagine that.
Imagine that. I'm sure they're out there.
There are some.
I'm sure there
are some, and there's some that don't start off that way and then end up going in a bad way.
Right.
But no, you would think going through the training that every other patient that calls your clinic is seeking drugs, and I can tell you in reality that is absolutely not the case.
Mm-mm.
I want to talk about the drug screen incident. I stopped doing the screens. I mean, I still do them, but I don't make. Hold on. There's a screen, urine drug screen, and then there's a confirmatory. So the confirmatory, we send that off to the lab, and they do more of an analysis on it and gives us the real deal. Okay. The actual screen that you pee in a cup and you make the decision in the clinic, I stopped doing those because of the frequent inaccuracies. False positive, false negatives, positive for meth. Well, I've never done meth. Well, it says meth right here. Let's send it off to the lab. Oh, sure enough, no meth. That's the kind of stuff we were getting.
Right.
I couldn't make sound decisions based on the screen. And it was affecting my relationships with my patients because, now they're running off thinking that their doctor thinks they're a bunch of, drug abusers. So many things can go wrong with the screening test. Whether false positive or false negative, I didn't find any value in it. So I do a confirmatory test every time. And then, you throw in the possibility of being a fast metabolizer or ultra fast metabolizer or slow metabolizer. That affects everything as well. And by the way, if you're new to the channel or you're new to the pain management world, you need to get yourself a genetic test. Ask your doctor, ask your pain doctor.
Yeah, but a lot of insurance, United Healthcare won't cover it. That's like $1,000.
I know. But
can you set me up on a payment plan? I'll do it.
No, I don't think I think cash for ours might be between $300 and $500. Don't quote me. It's still a lot of money, but it would give you so much information and it gives your doctor information. Well, a doctor who cares to use the information. If your pain medicine is running out, let's say at 2-3 hours when it should be lasting 5-6 hours, and you might be coming back to your pain doctor frequent, like, hey man, I really need more. It's not lasting me all day. I need more pills. And your doctor's like, oh, you're addicted. You're a drug seeker. And it's like, well, hold on now. Now you can throw a lab result in his face and say, look, actually I'm an ultra rapid metabolizer. Oh, well, that explains it. So then we can put you on a different medicine that's going to work better or adjust your timing dosing or anything like that. And you actually have a legitimate on paper, black and white reason for it. That can definitely be helpful. And I've had some patients, man, this one patient, she was a slow metabolizer, a CYP2D6, basically a non-metabolizer, so slow. So she couldn't convert hydrocodone into its active form.
Wow.
So basically she's eating hydrocodone all day with zero pain relief. Like the only pain relief she's getting is from the Tylenol. And she was on morphine forever. Now, morphine bypasses that enzyme, so you don't need, that doesn't matter. You can still get good pain relief. Well, anyway, that pain doctor that was prescribing the morphine went away, so she went to a new doctor, and then that doctor did not want to do the morphine, did not listen to the fact that she's been stable on this for 20-some years, put her on hydrocodone. She went into severe pain. Over the course of like 3 months, she was in the hospital like 6 times. The plan did not change. The doctor did not get a genetic test. Finally, she comes to me in tears. We get a genetic test right away, put her back on morphine right away. The next visit, like a week later, she's back to normal, like tearful and happy, like, thank you. And the test confirmed, yeah, indeed, you can't use hydrocodone. But if anybody had cared to look, or even just look at your past medical record or continue what was working, you wouldn't have been in this situation. So there's lots of problems, trust me. Trust me, you guys know more than I do. But definitely having the genetic test in your back pocket will definitely be helpful. Yeah, for a lot of things.
Yeah, I think I ran into that problem with I almost said methamphetamine.
What are you trying to tell me, Keith?
Yeah, with methadone.
Oh, yeah.
My previous pain doc gave me methadone, and it lasted for like 15 minutes, half hour. And it was supposed to go for like 8 hours.
Right.
And I went back and like, dude, this is like 15 minutes. And it's not great relief, but I can feel it for 15 minutes. It's helping. Well, that's when he dropped the famous line, Mr. Johnson, I am treating your pain. If you still hurt, that is your responsibility.
Oh, gosh.
I'll never forget that. Never.
By the way, if any of you don't quite know me yet and you see me smiling or laughing at these horrible stories, it is absolute disbelief that is causing this facial expression.
Yeah,
I'm not trying to show disrespect. This is unbelievable stuff.
It's come up before. Trust me, I've had tons of conversations with Doc, and it's just kind of I don't want to say a tick in a bad way. It's just how
I don't know what else to do. Like, are you kidding me?
Right.
Like, that's the
And
story?
so
That's horrible.
Trust me, it's not disrespectful. He's not trying to be disrespectful. He's not trying to laugh at anybody. It's just a normal response. And because he is blown away. If you guys go back to watching we did a series of podcasts. We did like 8 in one day. We recorded 8 in one day, or 6 in one day. And one of those was on ACE scores. And your response during that was just blown away about how it truly was happening.
Honestly,
right?
that was the first time I had a glimpse of the abuses that were going on. I mean, like I said, I understand sort of little things, but it sounds like, any sort of, advantage, let's say, whether worthy or not, a doctor can use against the patient. That's what's going to happen.
Any reason not to write a med.
Any reason not to write a med. And, yeah.
I cannot make that a blanket statement. I have to go back and to be honest with myself and say that's not every doctor.
No.
But I hear it so many times. Even Kimberly said in one of hers, 10 years she's being told it's in your head.
Yeah,
right?
the entire system is designed and around a physician to reduce opioid prescription. The entire system. You go against the system when you write an opioid prescription. And that's not an underwhelming statement. That's just the fact. So how do you overcome that? You have to create so much critical thinking, empathy, and patient understanding that it overwhelms the system. And that's, I think, what we're trying to do here.
Yep.
Right? Because, and actually, we're going to, hopefully, we would love to take this to the medical school, the university.
So if you believe in prayer, do that, whatever voodoo you do.
Yeah.
Right?
Well, because we want to give these guys that perspective, because I promise you right now, they're getting a perspective that is very anti-opioid. And no disrespect to the professors and physicians in that arena. Everybody has their own reasons, and I'm sure a lot of them are very good reasons. However, there needs to be, I think, a voice for the other side, at least to say, okay, well, maybe it's not end all, be all, never write an opioid prescription. Maybe that's not the right answer. Maybe the right answer is, okay, who is my patient and what is it that I'm treating?
Yep. What is their situation?
What's the situation? How are you going to manage that situation? You want to be a pain doctor? You want to be a big famous pain doctor and carry all the risk? Okay, then do it. Don't pretend play pain doctor with, I only do epidural injections and nothing else. I mean, you come up with a chart that says, I already had 60 injections and all you're going to offer is another injection. I'm sorry, you went to school for what?
Yeah. And I guess a simple way for me to put it is your patients are like fingerprints. We're all different. We are all different. I may have the same diagnosis as the guy in the exam room next to me, but how my body and my brain processes pain is completely different than the guy in that room next to me. Right? I may have a different goal. Get me to a 5 or a 6. I'm golden, man. I will leave you alone. Or this patient over here needs to be at a 3 or a 4. Or this patient is okay at a 9. God bless him for being able to. But we're all different. And that's the hard part is I know it's 15 minutes and I know, but just please pause. I know you guys have all this education and it's beautiful education and it took you so much work to get it. But honestly, I will fight to the grave telling you that I know my body better than you know my body. I know when something changes. I do these mental exercises starting at my toes all the way up to the top of my head and down to my fingertips. Is this new pain or is this existing pain? Is this the worst pain it's ever been? Do I need to go to the ER? Because if you do, let's go. Or can I handle this tonight? Is it new pain? Have you told your doc this yet? Because we do these exercises and we check on ourselves. Nobody wants another diagnosis. Nobody wants another symptom. Nobody wants that. But if it's something is new and we bring it to you, we know our bodies. We know it's new. We know it's changing. We know what's working. We know what's not working. Are there bad patients? Yes. I will get that out. I will agree to that all day long. Just like there's bad doctors, there are bad patients.
Yeah.
But let me prove to you I'm a bad patient. You'll catch me.
If you're a good doctor, you'll catch the bad patient.
Exactly. That's
if you're a bad doctor, you won't catch the good patients.
No, you'll miss them.
There's no benefit to being a bad doctor. It's just not.
No, not long term. How do you stay?
Yeah.
Go home and tell your wife she can't have the new Mercedes because you're a bad doctor. You don't have patience, right? I mean,
and for the record, you there are docs that are overprescribing and causing harm and at risk for being shut down. So I'm not suggesting that more prescribing equals better pain doctor or less prescribing equals less pain doctor. Good doctor. That's not what we're saying either. We're saying that each individual needs to be treated as an individual.
That's it. Simple concept, hard in practice. But it shouldn't be.
Right. As long as you're listening, that's the key. And I think I saw that earlier in the chat. The keyword for tonight can be, it's actually 2 words, just listen. If you guys want to type that in, just listen.
Especially after the video ends, put it in the comments.
Yeah, put it in the comments. That would be awesome.
That would be awesome.
Just listen.
Let's wrap out the the live chat tonight. Man, there's still so much we didn't get to. We're going to have to bring this back.
I know. We still have Scissortail's story, which is horrendous. And if anybody knows Scissortail from TikTok, Robin, you know the story. But it's one that needs to be kept at the forefront.
Okay.
Because it's tragic, but it's important. Her husband was just completely mistreated. But anyway.
A little cliffhanger for next time.
Yeah. Unfortunate. It's very sad. He ended up passing away.
Oh, my goodness.
But a lot of people here in the chat, they know Robin and they know his story. Not that I'm trying to discount it, Robin. I'm not. Because we're going to have a more in-depth conversation.
Some time spent on that. Okay. Yeah. Let's go through the chat here. Did I miss anything? Evelyn's sitting in the corner over here watching.
Just like, you guys miss so much.
I think we have a document that wants to be sent about ACE and POTS from a doctor. I'm assuming it's not great, but I'm going to try to see if we can get that sent before the live is over.
Okay.
Perfect. I think we have an email that we've been giving people, huh, Kevin?
Correct.
Yeah. If you want to put that email in the chat.
Is that Eclipse Unscripted?
That's correct.
Yep.
Cool. Yeah. Anything else? I'm gonna do some.
Just perusing here. Let's see. Lots of chat tonight, guys. I appreciate that.
Yeah, I appreciate you guys being here tonight and helping us get these stories out. Kimberly said it right. We can't hold these stories to ourselves. It doesn't do any good to be visible if we keep our mouths shut, and we need to do whatever we can to get our lived experience out there so we can hopefully affect some change. May not happen overnight, but it may not happen at all. But at least we're vocal. At least they know that we're here.
Kate Bakes, I have chronic renal disease now, joint injuries, and can't maintain nutrition orally due to 32 years of being ignored. Took 32 years to diagnose my genetic condition, which is EDS, Ehlers-Danlos syndrome, I presume you mean, which is the average age. Wow. Yeah.
Yeah, we could do a whole live on some of Kate's experiences. One of the last hospitalizations that they went through, I want to say it was like 4 days, no nutrition going into. I'll let them share that part of it. I don't want to get out of turn on that.
Why don't you go one up there, Kevin? Tracy, let's see, Sampson. Jamie, indeed they have. I am so weary of trying to politely advocate for myself. I am near giving up. I have carried pain since I was 16. I am so weary of trying without my doctors not even trying. Oh, man, Tracy. Don't give up.
Please
Please don't give up.
Reach out. KeithCPP@gmail.com. I think I'm pretty easy to find, or ask Kate or ask Jennifer in the chat, or if Leslie's around, they can get you my contact info. I don't know if I can be anything besides a sounding board, but let's see.
Yeah, and keep coming back. I mean, you will find that you're in good company, and there's a lot of support that can be had in this group, the Invisible No More group.
Big time.
We have had some success stories in the Invisible group. We had, I speak a lot about ketamine and how it's been a benefit to me. And there's a gentleman that messaged me today. I won't go into details, but he brought it up to his doctor, and now he's on a different form of ketamine, but it's based on ketamine. It's like a pure form of ketamine. And he said he had 7 good days in a row.
Wow,
and he said
awesome.
he said he could never before imagine that as a possibility in his life before this medicine that he's on now. And he's like, it was just people talking about it in the community about an opportunity. It doesn't work for everybody. And it doesn't work. You know, when we don't med shame or we don't treatment shame, we celebrate whatever the heck it is that works, right?
Yeah.
It gives people the opportunity. Like, this guy had never even thought of it. And his doctor was like, yeah, Velcro method, let's give it a shot.
Super.
So
Jamie Bates says, the hoops we have to jump through have increased substantially in the last 18 years. I have been a pain patient. Yeah. There's 2 reasons for that, I would suggest. The first reason is, obviously since 2011, you might say there's been a war on opioids. So that's one reason. And then number 2, thankfully, I would say, we just have a lot more options to treat pain with the technology and minimally invasive surgical interventions and things of that nature. And so I think there's been more of a push just naturally for non-opioid treatments. Can it be used in a way that's not helpful? Obviously, that's why we're here. But that is one of the things that I know has helped a lot of people. Ketamine, of course, being one of those things that can, let's call it another hoop if that's what you're after. But
does insurance drive that too?
Oh, insurance drives everything. Don't get me started, Keith.
Oh, I know. But as a chronic pain patient, I see it as insurance companies not wanting to pay for something expensive. So we're going to try to do PT before we do anything else. We're not going to, I don't want you to have meds. So we're going to have to go do this X, Y. We're going to have to go through a checklist before. Now,
I've had, obviously I'm a rehab doctor, so I'm a big believer in PT. I have a PT gym in my clinic. And a director of rehabilitation, Jose, as you've all seen on this channel. So I'm a big believer in physical therapy, strength coaching, things of that nature, exercise in general. But it's not going to work for every patient. There's going to be positive benefits, of course, but if your primary goal is pain reduction, actually the textbook itself, I can show you the pain textbook that they gave us to read in fellowship, says in there that physical therapy is not primarily for pain relief. It is not.
But yet it's prescribed for pain relief.
Correct. It's primarily, this is what the studies show and the conclusions and the textbook, physical therapy is primarily to maintain or improve function. If pain relief is a byproduct, then great. So a lot of times it puts me into a position of prescribing just to allow my patient to tolerate the 3 weeks or 6 weeks of physical therapy in order to get through whatever we need to get through onto the next thing. So if you feel as a patient that you have to jump through hoops, your physician also has to jump through hoops. And, not, I mean, just like opioids aren't for everybody, physical therapy ain't for everybody. I mean,
but that's the key. But see, doctors won't know that until you have that conversation with your patient.
Yeah.
Right. You won't know if I'm a good candidate for physical therapy, or if I'm a good candidate for opioids, or if I'm a good candidate for gabapentin until you have the conversation.
Right.
And we're willing to try these plans, and we're willing to do hoops, but make it worth it. Put some effort into it. Don't give me a generic patient plan that you printed off of Google before I walked in the door. Because
actually use ChatGPT.
Well, they do now, they do now.
Yeah.
But a lot of us just get generic treatment. Here's tramadol for 30 days, gabapentin for 30 days, go to PT for 6 weeks and come back.
Well, that's literally the insurance algorithm.
Well, I'm sure
that we're checking boxes. The advocacy for it is that, generally speaking, the progression of care has been well studied and established, and whatnot. However, again, we're applying population-based approaches to individuals, and that's where the system breaks down.
That's where it crashes.
Actually, I did a study. Oh man, now's not the time, but I will tell you later. I did a really cool study in our hospital. By changing one thing in the system, we maintained the satisfaction for pain management, but reduced opioid use significantly reduced opioid use with one change to the system. And this was done over just about 2 years and 7,000 patients near about.
Oh, wow.
It's a big study. I'll have to tell you about it later.
Speaking of studies, totally off topic. Didn't you tell me you're doing a paper on painsomnia?
Oh, well, a paper or
something, or an article or something on it.
We'll call it a patient handout. Education protocol, treatment protocol.
Did you ever finish it?
Like no, man.
Okay.
I got to get Chad on it. I don't know.
Oh, okay. All right. Because it's kicking my ass right now. Pardon my French. It's killing me right
Did you get my reel, though?
Yeah, about the guy, the insomnia sleeping.
Have you tried just sleeping?
Have you tried just sleeping?
Just put your head down, close your eyes.
I'll share that tomorrow.
Think of something peaceful.
So you guys can see what we're talking about. This friend of a person dealing with insomnia said, "Have you tried sleeping?" And he just goes off. You should write a book. How to fight insomnia. Sleep.
Just try sleeping.
Genius. Oh, your back hurts? Well, don't move. You should write a book. You solved my problem.
It sounds like a pain doctor wrote that one.
That's exactly, exactly.
Hey, we won. We didn't write an opioid prescription. Congratulations.
God, you're
Success.
comatose in bed.
Yeah.
I'm sorry. We're trying not to. We're not laughing at anybody. We're just laughing at the situation, y'all. Because if I don't laugh at some of this stuff, it just gets overcritical. We're blessed that we have a doctor that will not only hear our side but understands us, and we're blessed that we may have this opportunity to go talk to these baby docs. And all of y'all that shared tonight, bless you, thank you. We had more that we couldn't get on tonight. We're going to need to do this again, but I may not ask for more stories because I don't think I can mentally handle it right now. So
yeah, no, we still have a lot in the hopper. And if we didn't get to your story tonight, and you're watching this video, do not be alarmed. I have it cataloged, and we're gonna come at it at a later time. I promise.
Yeah.
So hang tight. But yes, on that note, thank you again for joining us tonight. We have a lot of cool episodes coming up. Actually, some very interesting people are going to be on the Dr. Dustin Show in the next few weeks. Some high profile, some behind the scenes type folks. And so we're very blessed to have them. We're going to be announcing some names here in the coming days. And so be on the lookout for that. And then, yes, Keith, we're going to circle back on this in the near future, I think, for another episode, because this has been eye-opening.
It's been good. And real quick, I want to plug Thursday night. Producer Jennifer, executive producer Jennifer, will be my guest on Thursday night.
Oh, fantastic.
And Jennifer has an incredible story. She is an invisible warrior. She kicks butt. She saves me every single Thursday. She is an incredible person and an incredible story. And it's finally an opportunity for people to meet executive producer Jennifer, and who really controls the show. So that's Thursday night.
I was wondering who was holding those strings above you there.
She runs the show, man. Between her and Amy, I'm controlled. Awesome. So
And of course, don't forget to come back Wednesday night with Katie and her show, Nourish and Thrive.
Yep.
And we'll get some good tips on what she has to share as well. And if there's nothing else, don't forget to log back out and put something into the comment section, if you will.
Just listen.
Just listen. That is the key word for tonight.
One last thing real quick, too. For Jennifer, I see your question out there. Can you still send a video? That is an absolute yes.
Yes, send me an event.
The montage that I'm going to be creating is for them to take to the baby docs.
So get it to me.
Correct.
Get it to me, and I'll get it to the right place.
Perfect.
So, okay.
For those of you who did share and were featured tonight, thank you so much.
Yes.
Your story really does strike a chord, not only with me, but I hope that it hits the chord of other physicians that may be watching, other patients, to give them hope that they're not alone. We're in this together, and we're going to keep talking and moving toward something better. Get some rest tonight. Have a wonderful week. We'll be in touch. Otherwise, we'll see you later.
Peace.